This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
Okay. Welcome back to the Alert Medic 1 podcast, everybody.
We're leaving that in.
Josh, Moose, and Cody, along with this team, Dr. Zaffer, Qasim. Thank you for coming back again, Doc, to talk about more great things trauma. And I'm going to hand it off to Cody to get us started on what all we're talking about tonight.
And thanks again for agreeing to come on and talk to us again. I know you guys are kind of going through it up there in Philly. Why don't you catch us up on what's kind of been going on?
Yeah, man. It's well, first of all, thanks for having me back on the podcast. I appreciate it. It's always fun to listen to you guys, and also an honor to be part of it. We've been having kind of a bad week up in Philly. Unfortunately, it's for those of you who've been keeping up on the news, on Saturday we had three of our nurses get injured, really kind of doing what they do on a daily basis, which is take care of kind of the sickest of the sick. And unfortunately, a GSW victim was brought in by private vehicle. And at one point, as the nurses were extricating that patient from the vehicle, the driver decided to take off, and in so doing, essentially ran over our team, and leaving one of our nurses critically injured on the ICU, and the others injured. But really, kind of as a whole ED family and the broader kind of the city, really in shock about this kind of brutal attack that essentially happened to our staff. Really, it's you shouldn't have to come to work thinking that you're going to get hurt trying to save lives. And to add insult to injury, just yesterday, one of our Philly fire medics was stabbed in the chest by a patient that they were about to transport, and left him pretty severely injured. Thankfully, is recovering now, but it just highlights the real danger that we face on the front lines. All of us, regardless of kind of what your specialty is or profession is, if you're working on the front line in healthcare, the risk of being assaulted is pretty significant. And I'll actually stand on my soapbox right now and say that it should not be tolerated. And we as a community and really from the federal level should probably be looking across the nation to bring offenders who do this kind of thing to strict and severe justice, as they do for folk who are assaulted in other walks of life. And so it's not something that we should just have to put up with. It's not acceptable. And hopefully, these horrible cases will highlight the need to get more action done on this front. So that's my kind of 2 cents on that. I'm sure you guys all feel the same.
Yeah, definitely. I'm curious, maybe you guys know, but are the penalties as strict when one of us gets assaulted or gets injured on the job as it is if it was assault on a police officer? Is it the same for us?
I think it is extremely variable. There is no really set standard. I've always heard rumblings of some kind of assault on a first responder penalty or charge, but I don't think it's ever happened. It takes a lot more to prove. I know when I had my instance of assault, because there was literally no evidence of it happening and I was not untowardly injured, they said the state's attorney's just they're not gonna pursue it. It's not enough. And I don't know if police officers hear the same thing on, and I don't want to belittle it, but minor assaults of a police officer, stuff that is not, running someone down with a vehicle, discharging a firearm against them or something, but just, something similar to what I experienced and had tried to pursue. Do they hear the same thing in return? That I don't know. So,
Yeah, I would say that's really an unacceptable situation. I think, there do exist laws, and whether they're, I've spoken to so many of my colleagues, and, working around in different healthcare systems, is that people sometimes just don't bother reporting because they've heard from a friend that nobody took it seriously. Or even if they kind of did pursue it, then by the time it got to the court system, then the charges were dropped for some reason or the other, and which puts people off from reporting. And so, really, I think the whole situation's unacceptable. It's not. I mean, we should have as equal protections as, say, someone. If you go to the airport and assault, say, a TSA agent, you're going to hear about that. That's it's not acceptable, and so why should it be
I
acceptable
think it's a
for
fair
us?
question. It's a fair question. But among some of the bad news that's come out of Philly lately, I was perusing LinkedIn one day, and I saw your post on this new paper, and I'll share my screen for 10 seconds so I can throw it up there for folks. I come across this paper. Oops, this one. There we go. The Contemporary Management of Traumatic Cardiac Arrest and Peri-Arrest States, a narrative review. And I'm trying to get my screen to stop sharing. There we go. There we go. So I'm perusing through this paper, and I see none other than Dr. Qasim's one of the co-authors, and also Dr. Perkins is on there as well. I've read some of his research, so I'll try to weave some different threads here with some of the stuff. Correct me if I'm wrong, but Dr. Perkins is a London HEMS guy?
Yeah, that's right. He's a trauma surgeon up in London, and a really great guy. He has done a lot of work on on traumatic cardiac arrest and just resuscitation in general. And really, I'd give credit to the first author on this, who's Luca Carenzo, who's a fantastic guy who works in Italy. I've known him through like social media for a while. I had a chance to meet him earlier in the year when I was in Milan, and he was gracious enough to show me around his where he worked, and the pre-hospital as well as hospital kind of set up in Italy. And he had this idea that we need to be talking a little bit more about traumatic arrest management and kind of the peri-arrest patient with traumatic injury. And so let's put this paper together. And he reached out to me and a bunch of colleagues, and we were able to put this together. So I'm glad that it caught your attention. That's really cool. And I'm happy to talk about it.
Yeah, you guys came up with a cooler acronym than I did for my piece. The hot. So I like this. It's like a hot topics kind of theme to it. And in that paper, so you pulled a paper.
That's right. Yeah.
Go ahead.
So certainly trying to remember kind of some of the key elements of that are important to address in traumatic arrest. So the HOT, HOTT, kind of take on this, addressing hypovolemia or hemorrhage, oxygenation, and then tension physiology from a pneumothorax and tamponade. And so that was the kind of the basis of the HOT algorithm, or acronym, which really aims to highlight some of the key things that you need to reverse for traumatic arrest or peri-arrest management.
So in the paper, you guys pulled a source. It was the Swedes actually that say there's a 10.6% 30-day survival rate in trauma arrest. And I guess kind of what I want to unpack through this and with the hot topics is, how do we give our patients that 10% chance of survival? So correct me if I'm wrong. You guys kind of put trauma arrest patients in kind of three buckets. You have the lost or the low output state in trauma. You have the NOST or NOST, the no output state in trauma, and then the peri-arrest patient. Should we be approaching each one of these kind of with the same like empirical approach? Should we just be running, volume through each one of them, get an airway and open the chest in each one of them? I mean, how would you suggest we approach this pre-hospital?
Yeah, so it's an interesting way to kind of look at these patients. Typically we'll think of patients who are pulseless as being in arrest, and I think it's for trauma at least. It's probably not the right way to look at it. So if you remember the trauma patient typically will die from one of two things. If you exclude kind of traumatic brain injury for a second, so either primarily they've bled out, which is the most common reason why they are in arrest, or they have some sort of tension pathophysiology like a pneumothorax or a tamponade. So as opposed to kind of medical cardiac arrest where you'll have cardiac ischemia and essentially a failure of the pump is still working in most trauma patients, especially a young, otherwise healthy person who has no other comorbidity. Their heart is trying really hard to put out some output. It just doesn't have something, or it's got an obstruction to that. And so this notion of a low output state, it really kind of emphasizes that the pump is working, but because of that low output, you're not getting even a central pulse. And so you might feel that the person has died, but actually if you put an ultrasound probe on their heart, for example, you'll see that the heart is still functioning. And those patients, in my opinion, are salvageable. So we need to be thinking about what we need to reverse in those patients. And again, that's where the hot algorithm kind of comes in. Certainly getting access early and restoring volume by all means after you control some external hemorrhage is really kind of at the forefront of managing these folk. And if some modifications you might be able to do to kind of confirm what you're dealing with is if you do have ultrasound capability or skill, it's not that hard to kind of just look at the heart and see, and all you're really looking for is one, is there cardiac activity? And two, maybe is there fluid around the heart that might be the reason why this person has deteriorated significantly. So I think these are modifications that are coming within the skill set of pre-hospital personnel and can certainly be brought into our management of traumatic cardiac arrest, which I think previously up until this point, well, I wouldn't say up until this point, but until recently, I think hasn't gotten as much kind of attention to what we need to do differently as medical cardiac arrest has.
I'll ask my question. It's not really a question, or maybe it's too early in the discussion to say. In that case, we can, let's say, edit this out. But why are we still doing compressions and traumatic arrest?
Yeah, culture, I would say.
Yeah,
if you see someone in arrest, what's we've always been taught this, right? That it's, you should start compressions, and that's kind of been built into us, whether we've seen it on TV and that's what we start emulating to do, or whether, that's what we've been taught is, as soon as you determine that somebody is quote unquote pulseless, then, you get on their chest. And I would say, in most people's kind of broad pre-hospital or in-hospital practice, you're probably going to see more medical cardiac arrest than traumatic arrest. And so it's instinct almost, right? It's, you just jump on their chest and start doing compressions. And so that's really kind of how I think people are wired to respond to this.
Yeah, it's interesting you bring that part up, Moose, and if we need to, we can also move this portion of it somewhere else within the talk if we want to bring it up again later. But Cody and I were actually just talking about this the other day, both through text, and then we actually kind of brought it up a little bit in a side discussion on another recording. And Doc, I think he and I both would agree. I don't want to take his words out of his mouth, but it's a 100% culture thing. I just floated this idea the other day to a couple like decent medics, and they all gave me like the all wide-eyed, like, what? You don't want to do compressions during traumatic arrest? I said, Yeah, and laid out why it's being looked at, and it's not something that's going to be adopted, I think, anytime soon in many agencies. But you know, I pointed to the public uproar that LAFD and LA County had when they rolled out their termination of resuscitation protocols during COVID, and everyone thought, "Oh my God, the fire department's going to show up and they're not going to try and save my family member."
Right.
And it was a very bastardization of what was put out, which is a protocol that is used in many other jurisdictions around the nation for many years. They just happened to adopt it then, and it got a little hairy there for a little bit for them. But this is one of those things. Like, if you're going to tell people, like, "Hey, we're going to show up," and that patient is perceived to be in traumatic arrest, we're not going to do compressions, which is what the public is expecting us to do, what other agencies are expecting us to do. We're going to do these other things, and then we're going to do compressions. It's going to just take everyone for a loop. I mean, it's going to be a roller coaster of reactions and emotions and drama.
Yeah, that's one of the things that you said at FAST this year, Doc, was good research doesn't always equal culture change.
Yeah, totally. You can present all the research that's out there, and there isn't, to be fair, there isn't much but physiologically and anatomically, it makes sense not to do compressions, right? But I think the way you need to look at it, like when you bring out these nuggets of evidence and try and apply it to clinical practice, you still have to think about how you would be as a clinician, and so. The key thing here, if you think about it, remember that, we do compressions because in medical cardiac arrest, we've seen clear literature that this BLS intervention really saves lives. And so early compressions, that's why we really push for increasing the uptake of bystander CPR. That's going to be key to survival or neurologically intact survival. And but as we alluded to a little earlier, the causes of traumatic arrest are primarily hemorrhage or an obstructive physiology. And so, if the pump's working in this instance, but it's got nothing to pump or it's got a blockage to pumping, then you pressing on the chest is not going to help. But, put it in the scenario like Josh, you were mentioning, where public perception is sometimes really important, perhaps even for, tying it into the beginning of this podcast for the safety of the crew. You often, the traumatic arrest patient is more likely to be found in quite possibly a more, say, hostile environment when you roll up. And so if a BLS crew rolls up who doesn't have the skills to provide a reversible intervention, for example, IV access, volume resuscitation, needle D, then by all means do the compressions. And even if ALS rolls up alongside BLS, then have your BLS crew continue compressions until you're able to get your stuff together to do those interventions. But I think the key thing to take away is that you don't want to delay the intervention. And if you're the only one that's able to do it, then sure, have your crew continue to do the compressions, but work really fast to get those interventions done. The challenge becomes if people become hesitant to do the interventions, right? Especially if they see their buddy on the chest, because you are going to be a little bit reluctant. There is going to be a little bit of inertia for you to stick a needle in someone's chest, or maybe even do an open finger thoracostomy if that's within your protocols, if your buddy's hands are right there. And that's, again, kind of some of the reasoning why we say now that compressions may be detrimental, because they can delay these life-saving interventions. But, read the room as well, especially in the pre-hospital setting. I think it's a little easier for me to advocate for this in the hospital setting, just because some of the logistics are slightly different. But in the pre-hospital setting, I think, read the room as well. Don't delay time to get that reversible intervention done.
Yeah, Doc, you bring up the chaotic scene. It reminds me of a story of one of my partners at work. They rolled up on a GSW to the chest, single gunshot wound, and found the patient in arrest, put pads on, found asystole by Maryland protocols. That's it. We're done. Time of death. It was at a vigil for another shooting, and
Oh, wow.
the scene was becoming very hostile towards everyone that wasn't part of the crowd. And so my partner made the decision, I'm going to load this patient up, even though traditionally we're not going to do anything. We're going to load him up. We're going to do compressions, and we're going to go to the hospital because we can't stay on scene here in the unit. We can't stay on scene here outside the unit. We need to get out of here. And that's one of those decisions where you have to make as a provider, like, what is going to be the safest option for everyone? And sometimes that safe option doesn't totally align with our protocols or our practices, and it's like kind of a gray area. It's okay. It's an acceptable gray area. It's not a negative. But it's one of those times where you got to really think about what's around you and what's going to do best for both the public, yourself, and just the situation. And, I'd like to kind of address this whole thing of like changing our mindset on compressions and priorities in a traumatic arrest, and remind other clinicians listening that we've done a lot in the medical realm. Obviously, Doc, you touched on that, that this is traumatic arrest has kind of gone by the wayside of improvements. There's some epi being removed by most protocols. I think that's probably the most recent one. But for the clinicians out there, we need to change our thinking, just like we need to change our thinking with drownings, overdose arrests, and respiratory-induced cardiac arrests. Our priority actually isn't compressions in these patients, because these patients are typically the healthier type that have a working heart that lost all their oxygen for a reason. So we need to prioritize ventilation, oxygenation, ET tube over SGA, but SGA if it's all that's available. That case, like, yeah, we're still going to do compressions, but our big thing is ventilation. And in our trauma patients, it's reversible causes. If we don't reverse these causes, it's all for naught. You're essentially, if you've got an obstructive physiology, you're pushing against a brick wall. That's it. You're just throwing blood against a brick wall, and it's going nowhere past that brick wall.
Yeah,
boom.
Totally. And I agree. I think for a long time, trauma arrest and maybe trauma initial resuscitation has always been kind of this cookbook thing that people have said, well, we just do this stuff, and then, they'll do the fancy stuff up in the operating room or in the ICU. But and I think that one of the big examples that everybody's talking about now, but if you think about it, we've been talking about for probably a couple of decades now, is this resuscitate before you intubate scenario where, you got to give blood and stop bleeding before you intubate these patients. Otherwise they won't do well. And it's not, this is something that we were talking about with like septic shock for a long time. I remember when Weingart came out with his lectures on this, and similarly other people were talking about this, several years ago. And that same principle really is applicable to trauma, but people just didn't think to apply it there, because I think they just felt that there wasn't much more that we could learn or adapt in trauma resuscitation as we do for our medical and critical care resuscitations.
Okay, I feel like we talked about the compressions a bunch, and maybe take it back to the paper, see what else we want to talk about there.
Well, I mean, the compressions are a big part of the paper,
Yeah.
As was like de-emphasization of that and epi. But one of the other things I liked in the paper was it talked a lot about hemorrhage control and kind of empiric use of pelvic binders with these patients. We may not suspect that there's traumatic bleeding right now, or I'm sorry, pelvic bleeding right now, but as we get things moving and as we get perfusion restored, we may find that there's bleeding in the pelvis. So it's a great idea to have that on earlier. Lost my train of thought. I hate it when that happens.
Well, let's focus on that. It's hemorrhage control, again, I think is something that we think of as pretty simple. And something, duh, you're obviously going to do that, but there are multiple compartments in the body that could hide blood, and so what are we doing about that? So, through the years, through the last couple of decades, and again, this is where war, really the only winner in war turns out to be medicine. But we've learned a lot, and we've innovated a lot, and so we've got tourniquets, which are great when applied appropriately for extremity injuries. But I think I don't think people have given enough thought about the benefit of these hemostatic agents that are out there, whether that's in powder form or whether that's in these impregnated gauze forms like the combat gauze and similar products. Because packing wounds and packing wounds effectively is a fantastic way of hemorrhage control. A lot of times, especially with, say, a stab wound or even a gunshot wound track, the bleeding may be deep within that track. And so really packing that wound appropriately can be a good, effective form of hemorrhage control. The pelvic binders, I think, again, people sometimes just aren't familiar with it, or maybe it's too cumbersome. And some of them, and I'll be honest, the teapot I find pretty cumbersome to put on. If you have other devices like lower profile devices, those are somewhat easier to put on. But I remember just a few months ago, I was running a pre-hospital physician car out of one of our sister cities an hour away from here. And I responded to a MVC where the vehicle had gone into a tree, and both occupants were ejected, and the patient I was evaluating was hypotensive, altered, and so I told the medic, "Hey, let's put a pelvic binder on this." And I remember saying, "Wow, this is the first time that I've actually put this on in practice," and it's just that people perhaps aren't thinking about what mechanisms of injury can lead to pelvic fractures. So certainly the key type of pelvic fracture that this is going to be beneficial to are open book pelvic fractures. And there's argument to say that the other forms of pelvic fractures, like a vertical shear or lateral compression, those types may not benefit from a pelvic binder. But again, in the pre-hospital setting, when you're faced with a hypotensive patient and where the mechanism is likely to potentially cause a significant pelvic fracture, then putting that binder on may still be beneficial. And so certainly at least thinking about it and talking about it and consciously then saying, no, I'm not going to do it in this case for this reason, rather than not thinking about it at all. It just adds to another mechanism for hemorrhage control that could be really life-saving.
Yeah, I think an easy way to think about it is if you've got a C-collar on a patient, you probably need to get a pelvic binder. The instance of pelvic injury is actually so much higher than cervical injury.
Yeah.
Like 6 or 7 times, if I remember my research correctly.
So something else to think about with the pelvic binders, and this kind of comes from the military, so I'll hit on what they have done to change their use of pelvic binders. First, they recognized that pelvic binders have a great use within combat casualties, especially blast injuries. And more specifically, as we go down this rabbit hole of stepping on a improvised explosive device or IED, and anything that involves blast injury to the lower extremities. So the energy required to inflict the injuries that we're going to see, partial amputations, manglement of lower extremities, is enough to also translate into the pelvis. And then you're going to have intra-abdominal, intra-pelvis bleeding. So I believe, don't quote me on this because it's been about a year since I've had to really have to pay attention to it. I believe any lower extremity trauma that involves an amputation or tourniquet application, maybe an IED blast, requires a pelvis binder in at least the Army's military medicine, because they recognize, like, hey, let's just get it on. It became a part of the combat medical set. Like your standard issued stuff for every medic gets a pelvic binder. So now let's translate that into the civilian world. Multi-system trauma. If you have any patient that has trauma to the upper torso and then the lower extremities, just throw it on if you have them, because the amount of energy or whatever happened to cause injuries in both those two different areas of the body probably involved the pelvis, whether it was a rotational injury, an open book, whatever it is. But we're better off putting it on than not. I know this was a huge hot topic in EMS social media like 6 months ago, and it comes up every now and then.
Oh my gosh, yeah.
But what I've gathered, I think what Cody, Doc, Moose, a lot of us gathered, it's better to put it on than not at all. It's kind of like what we talked about with stroke the other night. It's better to us not make the mistake. Don't be the one that causes the mistake. Just put it on, and put it on appropriately too, correctly.
Yeah.
Over the greater trochanter's, okay?
Yeah,
Please.
exactly. Yeah, it's malpositioned pelvic binders can be really bad. And it's interesting, a couple of things that you can do. So essentially, remember, especially with open book pelvis fractures, the pelvis essentially opens out, and so say you have a challenge putting on the pelvic binder, you can actually, as long as the legs are not fractured, you can actually rotate the legs inwards and tie the ankles together as well. And that essentially closes the pelvis as well. So that's another trick that you can do if you're logistically challenged to put a pelvic binder on for whatever reason. So there are other ways around it. I'm going to go back to a point that Cody raised about the cervical collar, because I certainly got a jolt up my spine about that. Penetrating trauma and cervical collars, please don't do it. It's how many times have I seen a guy brought in who's been shot and they have a cervical collar on, and I ask, why'd you put the cervical collar on? He goes, well, they got shot and fell. Like, okay, yeah, don't do that. There's clear harm in doing that. So because injuries are missed. So this cervical collar is on. Nobody wants to move the cervical collar. God forbid that you remove that. But then, oh, wait, they have this expanding hematoma around their neck that nobody's seen, because that's also where they've been shot. And so, there's a East management guideline on that. There's numerous anecdotal evidence about that. So please just ditch the cervical collar in those penetrating trauma patients.
You know what? I can't help but I'm so happy you brought this up, because I was just teaching the other night and I had this conversation. The same conversation occurs for other things too, right? And the idea of you have a limited cognitive currency, right? When you're treating these critically ill patients. What do I mean by that? You have limited brain power. And if you're the way our BLS education especially works is at the end, the C-spine is considered at the end of the scene survey, not even, before the primary assessment of, hey, is my patient going to die in the next 30 seconds? Before that, somehow we as educators put in that you got to care about the C-spine first, which is terrible. And similar to, the compressions, right? And I know that's controversial, but, again, as a clinician, you have limited bandwidth, you have limited, brain power, and you should be aligning that brain power to the things that give your patient the best chance. And I just get so frustrated when I see that C-collar be thrown out, or even worse, say there's an isolated, leg injury or something like that, and they fully spinally immobilize a patient. That scares me. That really scares me, because that shows that you're not understanding the underlying physiology of what's going on, the pathophysiology. You're following an algorithm that is going to harm your patients. It's so scary.
Yeah, totally. Along those lines, think about, especially with penetrating trauma, I think, what are the positions of physiologic benefit to your patient? So, you might, it might be harmful to lie your patient down if they have like a respiratory issue or airway issue. They might just be saved from any further intervention just by sitting them up. And we're kind of it's ingrained in us that we got to transport these people kind of flat and in our ambulances, but you don't have to. It's like, if they feel better sitting up, I can't lie down, I can't lie down, I can't breathe, listen to the patient. And, they might just be better off sitting up. So it's important to kind of consider some of these off protocol kind of approaches sometimes for improving the physiology of our patients.
I wonder historically how many people we killed because we spinally immobilized like a head injury that didn't need to be spinally immobilized. But
hey, we don't need to do PTSD.
Yeah,
okay? We already have enough. We don't need to think back on the ones that all the shit we did wrong.
Because I have a friend who's a neurosurgery resident, and he was telling me, we won't go into the specifics, but they had to do a saline bullet that he had to administer just so they could lay the guy flat to do a CT. And I'm like, oh my God, we've done like really bad head injury. We've backboarded really bad head injuries forever. How many people did we like induce herniation because of our stupid, practices? I don't know.
I mean, how often are we finding now that position of comfort, 45-degree semi-Fowlers is like the go-to for a lot of our transports. It has now become one of the first things we look for in a respiratory patient when we're treating them.
Yeah.
Semi-Fowlers or position of comfort. Don't lay them down. Strokes, 45-degree, elevate the head. Same thing with TBIs. With the whole backboard thing. We found that the mattress is good enough and the patient is good enough at maintaining their own I don't want to be in pain movements, and they're going to align correctly. Back to the whole, like, as we're like just taking C-collars and just, unloading into them. It's been brought up that to induce the injury that we're trying to protect by the C-collar, we don't have the amount of force available within our own human body to do it to someone else. Yet, if we don't do a pelvic binder, we are allowing the patient to keep on bleeding.
Mm-hmm.
And it's interesting to see these things, how, it's evolved, and it's just, luckily we're getting better. I will say that I think we're getting better as a profession as a whole when it comes to that kind of stuff.
Yeah, I agree.
So to throw gasoline on this fire, what are you laughing at?
Go, do it.
Is I want to talk about this.
Wait. Do we have a burn center immediately available or not?
Crystalloid versus blood in these situations.
Oh my God! No,
are we sealing their fate with the crystalloid, or if it's what we got, it's what we got?
You all wrote this so politically well, though. I just want to say that. Like, I just reread the fluid resuscitation section, and I'm just so impressed by the niceness of this. Yeah.
So now that you started off with burn, and now you've induced a stroke in me, so I hope both of those centers are available. Listen, it's so thankfully, I think we can all agree that this huge amount of crystalloid resuscitation that we were taught is kind of BS, right? And so, but it's still, even in the latest ATLS, it's still there. I'm sure it's in PHTLS as well. But you should replace what you're losing, and so giving blood back to the patient who is exsanguinating is really the key. And whether it's great, we can have an hour-long discussion about whole blood or components or whatever, but whatever you have to hand, it's better than crystalloid resuscitation, I think. But the challenge is, even though we're seeing more pre-hospital services getting blood on board, probably it's a vast minority compared to the services that don't have access to it. And so what do? You just, we can't give any fluid, and we're just going to just watch. And, I think none of us can just sit and watch and not do anything. And there was an interesting paper, and I can't remember exactly offhand, but they were talking about, what kind of volume you might be able to give and still not run into harm. And it was just under a liter of crystalloid that you might be able to give without kind of causing undue harm. So if you don't have anything else, and the person's circling the drain, and of course we'd like to give blood. Giving small volumes of crystalloid may not be super harmful, but I would kind of use it at things like 250 cc boluses rather than just running a liter wide open, and then reassessing response. So certainly, I think there's still some leeway in being able to give some crystalloid, but certainly not the 2 liters that we've been told to give in the past.
Yeah, a friend of mine that I've been to Refresher a couple times with when I was in the Army like to quote a tweet, and I'm sorry, everybody, I don't know who the doc is, and currently I don't know how to Google it to get this exact tweet to pop up, but he talked about how he would rather have his patients come in on the drier side than the wetter side when it comes to fluid resuscitation. Like really hug those permissive hypotension numbers, really hug those lines of like just on the edge of perfusion of what you're needing, but don't flood them. But yeah, be on the drier side than the wetter side.
I just listened to a podcast about this. It was trauma ICU rounds, I think, and they were talking to Maddox, and he was advocating for like systolics of 70 when he was researching the hypotensive resuscitation, and they kind of shut him down. Like the IRB shut it down and said, we like 90. So it's interesting to hear the backstory on how low they were advocating on the front end of it versus what we actually ended up studying.
Yeah, it's interesting. We always kind of look at this systolic of 90 as kind of our target. And I think for research purposes, it might be useful, but I think you do this job long enough and you've seen patients who have a systolic of 90 and look okay, and those who have a systolic of 90 and are clearly doing very bad. And so I think, we still need to individualize it a little bit, especially I think as we're seeing more older trauma patients. And so, everybody as they get older is more likely to have some additional comorbidity, and hypertension is certainly one of them, right? And so a patient who normally runs with systolics of 140, 150, 160, 90 is super low for that person. And so we need to understand that. And in fact, when we're looking at trauma activation criteria for geriatric populations, they're actually now changing and saying, the higher thresholds for systolics should be a trauma activation in those patients just for that very reason. So I don't think we can, realistically, it's as easy to just say, hey, 90 or 80 or 100 is the right one. And then you throw in, the potential for TBI. And so if there's an additional TBI, there's always that challenge, how do we stop bleeding from the trunk, but still maintain cerebral perfusion? And that's been a challenge that I don't think we've really answered. There was a really interesting pre-hospital paper recently that, again, kind of challenged that lower threshold of 90 to say that, we're not achieving good outcomes with brain injured patients for that. And we're actually suggesting that, we should be looking at maybe around 110 for those patients. And so, certainly thinking about, one, does my patient have a concomitant TBI? And if so, then, I need to be adjusting that. And then number two is, what other comorbidities does this patient have that I need to consider in my resuscitation strategy? So a couple of things to make it even more complex and make it less textbook.
Well, when you start talking about MAP and systolic for perfusion, and you think of the two things that we have to perfuse, there's the brain and the heart. You see that a MAP of 65 is actually pretty inadequate to perfuse those two things. So we see this number, we target this number, and we need to maybe challenge the mindset that 65 is enough, but it's actually the floor. That's the lowest you should allow. With respect to rebleeding and popping clots and things like that, in doing some research for a couple of things this last year, I've gotten kind of on the side of the fence of, do I want to pop a clot or do I want to hypoperfuse the brain? I'm not going to protect the clot at the cost of the brain.
You know, Cody, you bring up something good with that. Obviously, there's not a whole lot we can do about internal hemorrhage. Yes, we can do a pelvic binder for certain parts. There's some stuff that we're just never going to touch. The only thing that was going to even help with the resuscitation is whole blood or components. But, you know, we can't reach in and correct a bleeding spleen or a lacked liver or anything like that. But for your externals, like, I think it's a very fair thing to talk about, where do I pick the clot or the brain?
Mm.
External hemorrhage, we have many different ways to attempt to stop it or at least slow it. Like, hey, I get that our end goal is cessation of exsanguination. Okay, that is what we shoot for. But there are times where that is maybe not going to happen. Okay, let's just be honest. Like, but if we get in there and we at least slow it down to buy the extra time, at least that is something. And I'm not saying to cheapen your attempts. Do everything you can to do it. But sometimes some of these bleeds are just going to bleed, and it's going to need surgical correction. You know, I'm telling you, there's nothing you're going to do about a complete transection of a femoral artery. Guess what's going to fix that? Vascular surgery.
I don't know. I see Doc's wheels turning, and it says Reboa.
Oh, don't,
Reboa?
Cody, stop. No, we're not even. No, we're not going to. I can already see, you know, the flames of Reboa happening. But so, like, yeah, you have to determine what is best for your patient. And this kind of talk, you know, this, I like that you said this, because I was already thinking, you know, all these numbers, it's almost like a cookbook, but the cookbook is not definitive, because the cookbook is different for every patient.
Mm-hmm.
Because the patient and its disease process have their own ideas of what's going to happen. And you just have to actually pay attention to your patients. The 20-year-old stabbing patient is not going to be the same as the 80-year-old spider vein laceration, or, whatever you want to throw in there as their mechanism, or even their age. The 20-year-old stabbing is not the same as the other 20-year-old stabbing. To be quite honest, treat your patient appropriately. Watch for response, in skin, capnography, perfusion via the pleth wave, whole wide range of things we can assess and figure out, okay, this patient, I need to give a little more fluid to, or this patient, I'm good without fluid, or, trading the clot for the brain, stuff like that. I think everyone says that trauma is simple. Trauma is just, you just stop the bleeding, you get them to the hospital when it talks to, pre-hospital. But I think it's a little bit more nuanced than that. It's a little bit more in depth, and it takes a little more understanding of human physiology to know, like, hey, I know what I need to do with this patient. So
I wonder how much of this is like we are stuck in the cobwebs of just being rooted in treating medical cardiac arrest too, right? Like, we're just stuck in these cobwebs. I don't have a better term, because going back to the CPR thing, but now we're talking about, optimal map versus minimum map, because we are functioning from the lens of a primary cardiogenic issue, because that's kind of the root of CPR, right? But now, as we kind of put our, pop the clutch, go into second or third gear, we should be thinking of these patients as ultimately completely different patients, which I'm not sure folks do right now.
Yeah, I think that the challenge is, we bring up the MAP of 65, not even cardiac arrest management or medical arrest management, but it's, we always pluck this number from septic shock, which has gotten so much attention, and rightly so. But the big challenge, of course, or the big difference is that you haven't controlled the bleeding. And so the source control, so to speak, for trauma is that they're still bleeding. And so we can't just aim for that target. that we're so familiar with sepsis. And I think you're right. Again, kind of thinking about our cultural approach where, the majority of, unless you're working at shock trauma or a similar place, the majority of folk will see a huge mix of primarily medical stuff and some trauma mixed in. And so, we go with what we're familiar with, right? We fall to our level of our training. And so if that's what we're familiar with, then we tend to apply that to different pathophysiology that we see less of. So
to continue on through the paper, you guys hammered or did some nice foot stomp work with TXA and a little bit on calcium.
yeah.
I'm doing this just to twist the screws on Josh.
Huh. Yeah, so I don't know why we're still talking about whether or not to give TXA. Just give the damn TXA and the shock patient, man. It's like there's been some good work on it. Sure, it has some side effects, as do all medications, but again, you have to be alive to have those complications. So what is different, and certainly what we've changed even in our in-hospital practice, is to give 2-gram bolus up front. And I think some more pre-hospital agencies are starting to do that. And, the STAMP trial done out of Pittsburgh really showed a benefit of those most severely injured who got the 2-gram bolus up front. And I think logistically, it's also beneficial because if you think about it, you're giving that first gram over 10 minutes, and then the second gram was meant to go over 8 hours. And, you talk to your anesthesiology colleagues and they say, well, there's 100 things going on, and then we have limited IV access. And so hanging that drip up can be challenging. So logistically, it's even kind of easier to just get that up and out the way.
So to knock back to our first podcast with you, marginal gains. If we're doing this in front, then the hospital has less to worry about, and we can just be like, that's done. It's out of the way.
Yeah.
Move on with your higher level of care.
Yeah, totally.
Is the fear of messing with like TEG or ROTIM with TXA, is that valid in any way? Does it skew the results?
If you're addressing the fibrinolysis early on, then your TEG is going to reflect that you've treated it. It might, if anything, I'd rather have an improved TEG than, being late to the game and, having much more time, especially if you're in a system that has a long pre-hospital time where you're that much later on from point of injury or time of injury when they arrive to the hospital. So, it's okay. It's one more box that's ticked, and you can move on to addressing other aspects of the coagulopathy. And that's kind of leads nicely into the calcium question. So the calcium, I think, has become this big thing now, right? With the lethal diamond instead of the lethal triangle. And I think it's highlighted a key thing in so much that there's a few papers as a nice systematic review that came out recently that suggested that, around half of our trauma patients may be, who are in hemorrhagic shock, may be hypocalcemic on arrival. And so why not just give empiric calcium to everybody? You're going to be right half the time, right? So, and it can be beneficial because it kind of feeds into everything else. So acidosis will make calcium worse, and being hypothermic makes your calcium levels worse, and it all kind of is a vicious circle or diamond or whatever you want to use. Mm-hmm. But there's additional work that's shown that not only is hypocalcemia detrimental in terms of survival, but actually hypercalcemia can be bad too. And so you really are looking kind of at that Goldilocks approach where you want to be just right. And so I think my personal practice is changed. Rather than giving empiric calcium to everybody, is that if I have time that I can run a stat point of care blood gas and get an iCal, I'll do that. And I would say a significant portion of people can do that. Some places, some pre-hospital services have kind of point of care capability as well. So I think that's worth doing. But if I get a patient who's in arrest or peri-arrest, then I'll just take my chances and give them the calcium up front because more than likely, that might be beneficial to them, and we can deal with it afterwards if they are high, if we get them back. And so that's been kind of my approach to it. And it kind of follows, I've been looking at our patient population here at my hospital, and interestingly, people who I thought would be hypocalcemic were not, and vice versa. And so it is worth, if you have the time to look at that and see before you just go slamming calcium into these patients. So that's my kind of take on it.
I don't have any questions about calcium, but I do have questions about other things. If you guys have calcium stuff, then I'll hold off.
Go for it, man.
All right, so I kind of want to go
good.
backwards in the paper a little bit and talk about, we talked about fluid resuscitation, but we didn't really talk about the choice of access, which I found very interesting. Certainly in the pre-hospital education that I've received, and appears to be to me what the current understanding is, the common, for everyone, folks on the ground, is that IO equals IV, right? And the 50 cc's per minute is, as you guys clearly state in the paper, significantly lower than that of a peripheral IV or large caliber central venous catheter, right? So could you expand on that? Because that's kind of huge to pre-hospital medicine, I think, because in the past we've just considered it to be the same.
Yeah, so it's not certainly equivalent. They've done several kind of cadaveric studies primarily, and some kind of actual live human studies just to look at the flow. And remember, the IO needles are great advance in resuscitation. Number one, especially now with the drill type devices that are available, and multiple sites that you can use from just proximal tibia, distal femur to the humeral head. There's even a sternal IO device that's available for the civilian market too. But ultimately, what it has to do is to get into the vessels within the marrow of the bone, and then essentially go into the peripheral and then central circulation. So it does take some time to do that, and the flow rates, certainly even under pressure, haven't really equaled that of a large gauge IV placed in say your antecubital vein. So I'd say, certainly the go-to is a large bore peripheral IV. I think really it's if you can manage to get that in, two of them ideally, those are fantastic resuscitation lines. They are high flow, 14 or 16 gauge IVs in particular, and do the job. But the reality is, it's a challenge to get access in a shock trauma patient. Not only just from the shock itself, you might have the veins completely collapsed, and so even the most skilled folk who can put an IV in a rock can sometimes struggle with these patients. But look at the other patient population or factors that we are often dealing with, which are patients who have larger BMIs, and so hence have a large amount of subcutaneous tissue that you have to get through. And more, unfortunately, we see patients who suffer from IV drug abuse to also suffer injury as well. And so trying to access veins that are now non-existent can be impossible. And so the IO makes a nice kind of bridge to that, but I would say it's a bridge. And it really should be thought of that way as opposed to the definitive kind of access, in my opinion. It's a great way to start your resuscitation. The flows, while not super fast as compared to an IV, aren't zero. And so, it's better to have that access in, which you can get fairly rapidly in the different sites that I talked about. I would advocate for a site above the diaphragm, especially in if there's significant kind of torso injury, just for the fact that you might have a vascular injury below the diaphragm that prevents volume getting back up to the heart. So humeral IO would be my go-to. But then don't rest on your laurels once you get that done, right? So always be thinking, okay, this is my bridge to getting them something else. And that could be once you get, say, a unit of blood through there, that their veins start opening up and you can get a peripheral IV in them at that point. So always kind of think if you are going for IO, that's not the be all and end all. In my opinion, it's just a bridge to something else. Then the final thing that we talk about is the large bore central line, right? So the introducer sheath, the cordis, or whatever you end up calling it. These are large bore, so they are usually 7.5 to 8 to 9 French catheters that are placed using a Seldinger technique into a central vein. Typically, the subclavian vein has been traditionally chosen for resuscitation in trauma. And these are different than the triple lumen central lines that you'll see placed in other medical conditions that require state pressors. Triple lumen central catheters are not resuscitation lines because the individual lines are pretty narrow within that kind of core plastic. So if you cut it in half, you'll see that there's 3 small channels in there. And then the length of it, when you remember your physics, the length of it matters. And so these introducer sheets, these IVs that are 14 or 16 gauge, you see that they're short and wide bore. And so that's the key to being able to, through your physics calculations, being able to get that fluid through quickly. When you're struggling for access, IV being the first and foremost one, large bore peripheral, go ahead and put in an IO, but always be thinking, what am I going to do next? What am I going to do to get more definitive access in this patient?
Well, I think there's a few things here, right? Sorry, Josh, I had a couple follow-up things. So first, you mention in the paper, accessing jugular veins, right? Which is something that largely has, at least in my observations, has largely gone away with the utilization of IO. Certainly I haven't done it recently. I actually ran a trauma arrest maybe 6 months ago or maybe a year ago that I'll be completely honest with you. I was happy with the humeral head IO. I'll just be completely honest with you. Now I wasn't the primary on the paramedic. I was actually at my full-time job, which was a weird story. But other thing I can't help but think is, and I can't remember where I was taught this, I don't know. I would like to get your guys' thoughts on it, but using an IO and then doing a rapid flush to make the veins temporarily plump and then getting that access. I want to say this was something I learned from Dr. Lerner at Express Care. Maybe. I don't know. It's a faint memory thing.
I know a rapid flush opens up your canal, your intermedullary cavity better, so you can flow quicker.
Well, no. So I actually demonstrated this at the last cadaver lab I taught, where if you, even in a dead person's arm or leg, once you clear the space, if you follow it up with another rapid flush, oftentimes it's a temporary thing, but you're gonna temporarily plump up that the veins, especially if they have larger ACs, that might be, when we're really pushing for it, because I learned something today. Now I'm going to push for 14 gauges and 16 gauges in my trauma arrest patients. Not be happy with IO stuff. So I don't know if that's a viable thing.
I'm going to play a little devil's advocate.
Here we go.
Because Cody knows it because he and I talked about this. Okay, so this whole thing about 14s and 16s in trauma patients. I know the basis of this is trauma arrest, but overall they're trauma patients. I personally, this is Josh, this is not Alert Medic 1, this is Josh. Josh believes the 14 and 16 gauge catheter needles have almost no place in an ambulance anymore. Why? Why am I saying this? Even though we're talking about how the flow rates and everything. So we just got done talking about how crystalloid resuscitation, it's the majority of it's 99% of EMS agencies is what they're doing. So if we throw say we do the bridge, say we do an eye only bridge the patient to a 14 or 16 gauge. Looking at the flow rates, a 16 is reported to be about 180 mLs per minute, and a 14 is 240. We then have to rely on the medic to pay attention long enough to realize that they just dropped possibly a liter of fluid into a patient. And I'm just saying that because, like, you know, you get wrapped up, you get that line in, you're like, hey, BLS provider, can you hook this up? I'm going to focus on this other thing. And then, time blindness, time warp. 5 minutes later, you look up and you have an empty bag. And you're like, oh, crap. And so, like,
that's fair. That's fair, bro. I see where you're coming from.
And it's so, like, then people would interject. Oh, well, what about for blood? Well, I gave blood through a 20 gauge the other day with a life flow handle. It worked great, and it did its job, and the patient's blood pressure responded. Mental status responded well, and everything. I know Cody offered up some ideas that it destroys platelets as it goes through the smaller gauge, but like, I have a really hard time believing today with our current protocols, at least in EMS, and I get in hospitals completely different because of massive transfusion protocols, rapid infusers, stuff like that. I don't feel like the 14 and 16 have as much room in EMS as they used to. I get kind of maybe setting up the hospital for success. So you don't have to do the one when they get into the trauma bay. Once again, marginal gains. I have a hard time using them. I'll be honest. The last time I used a 16, I cannot remember. I don't think I've ever used a 14 in 7 years.
I don't think I've ever used a 14 either. I've definitely used a 16.
And like, it's tough. I feel like I'm arguing against you personally, Doc, with this topic, because you just argued so hard for the 14 and the 16. I just, the trauma patient, like you said, likely has flat veins. I think about some of the stuff that the vascular guy talks about, vein to catheter ratio. Does the 14 and 16 actually appropriately sit within inside these veins correctly and do its job? Or are we causing possibly tertiary harm picking the wrong size catheter? Why, is an 18 going to do the same thing better because it fits in the vein better? Stuff like that. It's just thoughts, Josh's personal thoughts about 14s and 16s. I know it's talked about a little bit, but they're still held with some high regard by some people.
Couldn't we fix the fluid issue with pumps, though?
Yes. Yeah.
I mean, that's just a practice issue that we're messing up on, right? As EMS in general, like, I mean, I don't know if I agree or disagree with you, Josh. I'm just saying
it's probably a practice issue, because it is on the clinician to acknowledge, like, hey, I'm putting this large bore catheter in and I'm about to dump fluid. Like,
but that's not what I meant, though, because it's not fair to. I truly don't think it's fair to expect a paramedic who's doing a million other things. I actually agree with you, Josh, that again, cognitive overload. Having that limited capacity, but I mean by not having pumps for a million other reasons, but not especially also in this situation, for just a ton of fluid.
At the same time, I think it's winning some parts and losing other parts at the same time. So our whole goal of the 14 is to get fluid in fast. I mean, I think that's we would all understand that, but the pump, regardless of what catheter you put on the end of it, is going to go at 250 mLs per minute for over 15 minutes. Okay, what's available out of hospital, that's all it'll do. I don't know about the Baxter. I know the Sapphire. That's what I'm personally comfortable with. They straight up said it would have to be made 25% bigger to get a faster flow rate, but it's maxed at 250 mLs per 15 minutes. So, like, why did you just drop a 14 when an 18 is going to do the same exact thing? Because you're bound by the pump and its abilities. So, but at the same time, cognitive offload, you don't have to pay attention to the 250 you're putting in.
So here, since you were devil's advocate, can I be like angel's advocate? And say, rather than saying don't stock 14 and 16 gauge IVs, don't stock liter bags of crystalloid. Especially now I can say it with the shortage that we're facing with IV fluid. So,
That is
but
that's a great counter, Doc. I agree wholeheartedly. That's something that comes up with the pumps. Like, my medical director says, well, I want 250 at a time every
yeah,
15 minutes. Well, then give us 250 bags and we just let it go by gravity and we just don't worry about it. And then we reassess at 250. Okay.
yeah, and
Or,
I
or
think
500 bags.
yeah, totally. I wanted to go back just to that trick that was talking about. So another trick that you can do is actually, I've done this. I put two tourniquets on, and I put a smaller gauge IV in the hand, and then kept the tourniquet on, and then flushed through that line, and that can sometimes pop up some veins more proximally. So you can do that trick as well. And I think the EJ is a great access. But I think it's a skill that people have lost. It's a challenge to get into it. The lighting, if the lighting's off, you can't see the vein properly. It's ideal if they're tilted down a little bit. But if you can get it, and a lot of, actually, we were talking about, people who abuse IV drugs, and a lot of times their EJs are still intact because they haven't used those. And so that might be a good vein to choose. The third thing, though, I think, Josh, you mentioned the life flow device. I don't think that, all these tables and stuff that we use to judge IV flow rates have factored in devices like life flow yet. And so, it's a good point that you make that, potentially what we thought would be the real benefit of that 14 gauge IV because of its innate flow rate because of physics is ameliorated by the use of the live flow because you can do the same thing through an 18 gauge now and get that flow much faster. So I think, if you have those adjuncts, then that can maybe change your decision making a little bit. I'll still keep that 14 gauge or 16 gauge on the rig.
And to be fair, I completely understand keeping 14s and 16s in the trauma bay. That makes a lot more sense than EMS. And I think of more of along the lines of rapid infusers and massive transfusion protocols. You really want to get a lot of volume in quickly. You have a machine that's going to do it and a machine that's going to match the flow rate of those catheters. So that makes 100% sense. I agree.
I wanted to. Oh, sorry, Cody, go ahead.
Go for it.
Because I got a couple things. So you can go and then I can go if you want.
Go for it.
All right. So next thing I want to touch on is the airway management section. I think you guys said it very well. That hold on, let me find the particular. I tried highlighting it, but the software is kind of funky. During the initial phase of the resuscitation, basic airway maneuvers and simple two-handed bag valve mask ventilation or ventilation through supraglottic airway devices may serve this purpose. Therefore, time-consuming and resource-intensive airway securing procedures such as endotracheal intubation should be deliberately de-emphasized or postponed during the very early phase of the resuscitation. I just got into well, I shouldn't say with who, but I was in a teaching scenario and I was going back and forth with someone that, and this was a medical scenario. This was after the first shock. This person wanted to intubate, and I was like, "Listen, I made the same argument of you have limited cognitive capacity. You should be aligning yourself with the things that are going to save the patient, not dropping a tube." But this is a similar thing. But then you all also say that although this review focuses primarily on hemorrhagic and or obstructive traumatic cardiac arrest, specific etiologies of traumatic cardiac arrest can benefit from early advanced airway management, such as that caused by asphyxia, drowning, and isolated traumatic brain injury. So I guess I should take a step back. And one of the things I've been really evaluating myself on and seeing in EMS is this idea of dichotomous thinking, right? We either say go or no go, and we've talked about it before on the podcast. But I just loved how you guys wrote that section because it really says that there's never black or white. There's always that it depends on the situation. So I was hoping you could comment on that.
Yeah, it's a great and really hot topic. I think kind of goes back to the general principle of resuscitate before you intubate, and we've seen the same thing with trauma. It's just I think we put a focus on it much later than we have for non-trauma pathophysiology. So just to kind of talk a little bit about the physiology and why we're thinking about this. So we have a shocked patient who's shocked in this case due to hypovolemia primarily. You then might need to give them some RSI meds, which even if you give like ketamine or etomidate, which are typically cardiostable, so quote unquote, if you give like normal doses to shock patients, you can still induce vasodilation in them. And then you put a tube down and you induce positive pressure ventilation, meaning that their preload is decreased. That's going to cause post-intubation hypotension and cardiac arrest. And so there's ample literature that has shown that in a number of different critical scenarios, and that's really kind of where our emphasis has changed. So we saw this really even at our center several years ago, where we kind of realized that there was a benefit to one, stopping hemorrhage and then restoring circulation before intubating patients. And so in general, the number of intubations we've ended up doing in the emergency department has decreased significantly for trauma. A lot of times the initial resuscitation happens and they'll go up to the operating room and they'll be intubated just before they start operating on them. And that's really kind of changed our practice and actually has improved outcomes in terms of decreasing post-intubation hypotension events. And so that principle has really kind of expanded. And so a lot of people are saying that this, instead of ABC, they use this CAB approach, circulation first, and then moving to airway and breathing. I think when you look at the practice of how that's going to affect some of the surgeons, it's been challenging in some ways, to the point that some people become staunchly against any sort of airway intervention, even when it's indicated. I think that's where, again, we can't just do this single model for everybody. So I am a huge advocate for controlling hemorrhage and restoring circulation early. But, those basic airway maneuvers you can certainly do and should be doing to support those airways beforehand. And it might be, that they have an altered mental status or depressed GCS because of the fact that they're so hypovolemic and malperfusing their brain. And, we've seen several patients now that you give them a couple of units of blood and then they start waking up and talking. And so you don't need to intubate them anyway. So that's great. But, what about those patients who have significant chest wall injury or markedly hypoxemic, have an airway injury, have airway obstruction or something like that? Those people still need advanced airway intervention. And so, look at your patient rather than looking at just a unilateral protocol. Those patients need to have their airway addressed. And it might still be that you change things around. You could still try your best to, get your access and start your volume resuscitation while you proceed with the RSI at that point. But don't just say, hey, no, I can't do anything with the airway for any trauma patient until we've given them a couple of units of blood or whatever, because some patients still need their airway definitively managed early on because of the injury pattern that happens. So yes, in general, restore circulation and use basic airway maneuvers first, but there are patients, yes, that will benefit from early intubation, especially because of direct injury. And then you mentioned also TBI patients, and we know that our job really is to prevent secondary brain injury, and part of that sometimes is being able to manage their oxygenation and ventilation through intubation early. And so, not all trauma patients can be thrown into one box. You need to think about these things before moving forward. But in general, rushing and saying, okay, I need to definitively manage the airway before doing anything else. Yeah, you can probably throw that out the window and still kind of modify that. And I think March works better in some ways to address this than kind of doing CAB because it kind of nuances those things a little bit better. Yeah, trauma, as it turns out, is a little bit more complex than we thought.
Perfect. I think I got two things left. I loved the treatment of obstructive shock pathology section. That was awesome. I'll tell you the first thing I learned. I should mention the first thing I'll say is what I learned, which was a ton. Specifically this sentence: while the latest treatment recommendations from Advanced Trauma Life Support (ATLS) suggest placing the needle in the fifth intercostal space, just anterior to the mid-axillary line, the evidence supporting this recommendation is weak. And I felt like the earth shook a little when I read that. And the available data on the topic are highly heterogeneous. Additionally, Aziz et al. Demonstrated that in overweight and obese patients, the chest, which is a large portion of our patient population, right? Because we're not treating military age males, which we've always talked about how the biases from the military to the civilian world. The chest wall is thicker in the fifth intercostal space in the interior axillary line than in the second intercostal space. In the mid-clavicular line, leading to theoretically higher successes. But then you all go on to say, even with placement in the second intercostal space, however, a certain percentage of needle thoracostomies don't make it, right, for whatever reason, which we've also known. Therefore, ultimately, we get to finger thoracostomy. So I was hoping you could comment on that, and specifically comment on it, if you don't mind, in the setting of you're popping the hole. Some folks would say, "Oh, well, you're popping the hole, you're relieving the pressure, but you're also not backfilling it with anything." So if you could just comment on all that, please.
Yeah, sure. So let's start off with needles. So certainly, there's a huge potential for benefit from needle decompression if that's the only skill that you have. And traditionally, we've been taught to do second intercostal space. Really, even though the teaching is there in practice, there was this great paper that came out from Ireland that showed that, when people are actually asked where to point out where that space was, a lot of people, say about 2/3 of folk, didn't really know where it was. Either they went too medial, so they risked injury to mediastinal structures. And clinically, I've seen that once or twice where the needle's clearly been in the wrong place. And so this move to lateral, you look at the papers, they all looked at kind of CT imaging, measured the chest wall and everything, and said, it's thinner laterally, so go with that. And that kind of made its way to ATLS. And I think that's an interesting change. But again, as you say, when a healthy, lean, muscular person is laying flat on his back, his or her back, then their muscle tissues stay in one place, as opposed to a high BMI patient who, as they lay on their back supine, all their tissue by gravity will fall laterally. And so clearly make it more challenging to access that space. And so, again, not kind of a uniform success rate in that patient population. And then I think you should also look at, how we're teaching where this fourth intercostal space anterior axillary line is. So one of the big challenges that I've seen is that people end up putting the needle too low. And the reason for that, I think, is because we forget that as we kind of move laterally with our ribs, the ribs curve, right? And so they curve outwards, upwards, into the axilla. The space between ribs is much smaller laterally than it is anteriorly. And what's, say, in the fourth intercostal space here is actually way up here when you have the arm raised and lateral. So this leads to, if people move straight across thinking that that space is there, they'll cross over into a much lower space and run the risk of putting the needle into the spleen or the liver. And so that's one of the things that we need to remember when we're teaching, that you realize how the anatomy works. Number two, that it can cause injuries, if the size of the dart that you're stalking, especially if you move to the decompressing the left side of the chest. Some of those darts, and there was a recent paper in JSOM that looked at this, get pretty close to, if not right at, where the apex of the heart ends up being. And so if your practice is to hub the needle, and you're using those longer needles, and I think more people are stocking those, then that certainly runs the risk of causing damage there. So clearly, the benefit then is lost if you're doing that. So keeping those things in mind, it really just means, it's not a bad practice to go laterally, but when you're teaching it, teach those considerations as well, so that people come with the knowledge that of how to do this and how to do it the right way. So open thoracostomy or finger thoracostomy is much better, in my opinion, way to do it, because you're guaranteed to feel your way into the pleural space and be able to kind of access it and open it up and relieve whatever's causing the tension. It does require certainly more skill to be able to do that. Some EMS agencies in the States have actually put that into their protocol, so it's not out with the realm of non-physicians to do that. So certainly, if that's a practice that, in conjunction with the medical director, is something you want to move to, then it's certainly feasible to do that. I think the benefit is not only that you're able to kind of make sure that you're in the right spot, but the additional benefit is that if, one of the challenges that we have in needles is that either it dislodges or kinks or something and restores that obstructive pathophysiology. So if that were to happen with an open thoracostomy, you could just put your finger back into the hole and make sure that you can open that up again and actually relieve anything that might have recurred there. So there's certainly benefits into doing that. And then, Moose, I forgot what the last point that you were asking about.
Just the I'm not making this point, but I've heard this point before. That what's the point of doing a finger thoracostomy if you don't have anything to fill it on the back end? I didn't know if you had any thoughts on that, like with whole blood.
Oh, okay, all right, yeah. So, well, if the cause of the tension is a pneumothorax, then I think it makes perfect sense, right? So, it might be that they haven't actually bled out, but they have just a pneumothorax that has turned into a tension, and so relieving that can be life-saving. Problem is, if you do have a massive hemothorax, for example, and then they start exsanguinating out of that. One, you might not know until you actually end up doing the procedure. So, the question is, this person's dying, so do I do it or not? It might be a pneumothorax, might be a hemothorax, who knows? And I think in that instance, if it does turn out to be hosing out and you're 30 minutes away from a hospital, yeah, you don't win them all, unfortunately. So, but I think, I'd rather do it and with the hope that, I'll reverse something that's reversible, as opposed to, the smaller chance that they might just end up exsanguinating out from that hole. So
absolutely. No, I certainly appreciate that. Cody, I apologize for monopolizing the time. I have one more thing, if that's okay.
Go for it.
And that is, I'm not going to talk about Reboa, but I want to get your thoughts.
This is the second mention of Reboa. Let me just turn the light on real quick.
Sure. But what I do want to bring up are these external abdominal constriction devices that I've been seeing pop up, and just your thoughts on it. And I don't know. Whenever I see Reboa now, obviously Reboa to me is not feasible without a lot of physician resources in the pre-hospital setting. I think that's a fair statement to say. That might be controversial to a lot of people, but I think that's fair. But what I do think is possible is using some like a non-invasive thing like these tourniquets. So I just want to get your thoughts on that.
Yeah, I think there's been, we face this continuing challenge of non-compressible torso hemorrhage, right? And so there's been a lot of effort from the commercial side to kind of get devices to be able to do that. And you're right, using Reboa certainly requires some skill and nuance and stuff, and more importantly, kind of a systems approach that can support its use. So it's not certainly in, I would say, the majority of U.S. systems' ability to do. So, why not these devices like the abdominal aortic junctional tourniquet or other similar junctional tourniquets that have come out there? If you look at the available evidence, it's not great one way or the other. There's been some comparison studies to like zone 3 Reboa, meaning that occlusion at the bifurcation of the aorta, and have shown kind of variable outcomes. There's still kind of problems with ischemic injury that can happen or damage to structures like the bowel and the bladder. But I would say that, if you have nothing else and your service decides to stock these and you have an injury pattern that might be amenable to it, I would say, understanding the limitations of it, you can probably still go ahead and apply it. There's not a whole lot else that you would be able to do for this person. You could use up your whole blood supply, and if they're still exsanguinating into their belly, then what are you actually gaining from that? So even though it might not have the best science around it, the science around Reboa is pretty variable, as you guys well know. And so if this is a non-invasive way that can be taught easily, is something that you can maintain a skill on, and it's the only thing you have between this person dying or not, then I would say, go ahead and use it, because there's not much other choice that you have at that point.
Very fair. Thank you. And Cody, I appreciate your patience. Thanks, brother.
Man, it's a team for a reason.
Cody needs some additional time because he blanked out in between. So I think he should get extra minutes.
The one thing I want to bring up from the paper is you don't have just the hot mnemonic. You've got two more that go along with it. And one of the big things that sticks out to me is making sure we know what the presenting rhythm is.
Yeah.
How important is that? Because one of your co-authors did a paper a while back that said maybe there's some, I hate to use this word, but some predictive value in that presenting rhythm.
Yeah, it's a really interesting topic, and I think something that we'll probably focus on more in the future is that, there's this theory that, and this kind of goes back to how with our advances in pre-hospital care, we're bringing sicker patients to the hospital, patients sometimes who might never have survived in the past. And so, and yet some of those still end up dying on the ICU a few days later. And so what are we missing? And so there's discussion about whether patients in severe hemorrhagic shock actually potentially also undergo some sort of cardiogenic shock component as well, so that their heart actually just becomes dysfunctional as a result of the intense kind of stress that's induced, or whether it's due to myocardial ischemia. It's unclear exactly what, and there's still probably a lot of work to do to kind of define that, but that's kind of the working theory. And so Zane Perkins, who we talked about earlier, is due to publish some really interesting data on pre-hospital thoracotomies. As you know, in London's Air Ambulance, they have been doing pre-hospital thoracotomies in some of their patients for a number of years now. And so what Zane did was actually look at survival related to the cardiac rhythm that was present at the time that the thoracotomy was done, and found that people who had some form of narrow complex rhythm, whether that manifested as PEA, but essentially was like a sinus rhythm or sinus tachy or sinus brady, you're probably getting more towards the person dying. But as long as it was narrow complex, their outcomes were a lot better, in particular sinus rhythm and sinus tachycardia, as opposed to when they start broadening their complex and go into even shockable and ultimately non-shockable rhythms. And so having that information can certainly perhaps in a system that's not doing thoracotomies or other things might help facilitate some discussions about whether we use a finite resource like blood. So if you come across a patient, they're clearly like this broad complex agonal rhythm, then maybe your resuscitative efforts aren't really going to be beneficial for this person, as opposed to someone who's got a more narrow complex. And then similarly, this kind of also goes into a paper that had come out a few years ago from LA County, where they looked at who might survive if you did a thoracotomy. And they found again that as long as you have either an or some sort of cardiac activity or a fluid around the heart, meaning like a tamponade physiology, those patients were more likely to survive. And if neither of those were present, then the survival was zero. And so the heart is something that perhaps we haven't given as much attention to in terms of what its response is to severe hemorrhagic shock. But I thought the data that was coming out from London was fascinating. And certainly I think this is going to be a focus of more study around the world in terms of how much that might factor in different systems to decide, who's actually going to be surviving from this and who's not.
And real quick, I'm so sorry. This was something I wanted to comment on. Could you just real quick rehash? I got a phone call. I apologize. The arrhythmias, the differentiation, and then Cody, go. Sorry.
Yeah. So we were talking about Zane's work was showing in pre-hospital thoracotomies, those people who were more likely to survive with good neurologic outcomes were those who had narrow complex rhythms. And so sinus rhythm, sinus tachy, and maybe a few with sinus brady, although that's often kind of preceding death, much more likely than if they started broadening out their complexes and moved into, shockable or non-shockable rhythms. The narrower the complex, the more likely that they might have a good outcome.
I'm happy you said that because the reason we switched our Maryland protocol from like the standard H's and T's to like this, it's a guy by the name of Lazo Littman in North Carolina talked about the rational approach to PEA and approaching it in a wide complex versus narrow complex thing. So that's why I thank you for repeating that. I apologize to listeners, and Cody, I'll shut up now.
Well, no, because what you said kind of marries what I was going to say is that should we be requesting termination of resuscitation in the presence of narrow complex PEA? And is it smarter in trauma to just assume that a PEA arrest in trauma is secondary to hypovolemia, tamponade, obstructive physiology, and maybe we should get those folks to the trauma center instead of calling them in the field?
Yeah, totally. This is where, that concept of lost or low output state in trauma comes back into, right? So it's just because you can't feel the pulse, but their heart's still working and they have a narrow complex on the rhythm. They're not in arrest, technically. They're just in profound hemorrhagic shock. And so these are the ones that are more likely to respond to aggressive intervention, volume restoration, and those other things that we've been talking about. And so, yeah, I agree. We should give those people a chance. And so, getting that information early, I think, will help us in our decision making about what to do with these patients and what to do en route as we get to the trauma center. And so, certainly, yes, I agree. Include that information.
There's a case for ultrasound in there. To take a look at the heart.
Yeah, totally. And it's, again, well within the skill set of non-physicians to do that. And so as we're seeing around the world. And so why not use all those tools? This is the patient that would benefit, especially, if you think about who is affected by trauma, especially in this country, is young, otherwise healthy folk. And why are we giving up on them unnecessarily because we can't feel a pulse? Well, of course you can't feel a pulse because, their heart's struggling, but, you're not generating that output because there's nothing to pump.
And for you folks that are listening that want to get a little bit deeper into what Doc's talking about with Zane Perkins's work, on YouTube, the Big Sick Conference puts all of the presentations up there. And I believe it's Big Sick 23 where Dr. Perkins unpacks this maybe there's a window of survivability related to I believe it's exsanguination and tamponade overlaid with organized or disorganized cardiac activity, and it's somewhere like 5 to 15 minutes depending on what that primary problem is.
Yeah,
So
totally. He's already put all the data out there in presentation, so hence I'm happy to talk about it. But yeah, you're right. It's available on YouTube.
Moose, what do you got, man?
I got nothing. Honestly, I think I asked all my questions already. I was gonna make a comment on vasopressor use, but I think folks should go read it for themselves because it's very clear and it's very concise. And I don't want to take up any more time. So no, we're good.
Did we lose Josh?
Yeah, I think he had to disconnect.
Okay.
So I'll let you finish it up, Doc. What should people be taking away from this paper, especially us, this non-physician group? What should we be walking away with this?
Yeah, I think the bottom line is that we need to rethink how we're approaching the really sick trauma patient who's kind of peri-arrest or in arrest, because it's not as straightforward as we were once led to believe. There's a lot of nuance to it, and actually a lot of the basic early work that we can do in terms of our clinical skills and things can actually save some of these patients. We're already, depending on where you look, between 20 to 30% of patients who suffer trauma in this country have what are called preventable deaths, meaning that they are dying unnecessarily. And if we just intervene in some way more aggressively for those patients, we can cut that rate back down. There was a big white paper that was put out by the National Academies of Science to that topic. And so hopefully this paper, as well as this discussion, will get people to rethink their approach, even in some simple ways, like thinking about restoring volume early and using basic airway maneuvers, or looking at cardiac rhythm, which is a fairly straightforward thing to do, and changing your approach that way might save one or two extra people. And I think overall, if everybody does that, then that's going to be a big win for society.
Huge win. Huge win. Zach, we appreciate you taking the time to talk with us and unpack this. I would say to everybody listening, good night wherever you're listening. And we'll see you on the next one.
Yeah, thanks so much for having me. It's always fun.
Thank you.